In other words, this corticobulbar is akin to the corticospinal tract. The only difference is this corticospinal control where? From the neck down to the pinto, but corticobulbar control where? Head. Everybody get that? Good. Now let me tell you something else. This corticospinal, we're talking about corticobulbar, they're using the corticospinal as an analogy. Right? This corticospinal is going to end where?
In the C2, I think.
No, where does it end? Tell me specifically where. It ends in the spinal cord. Where exactly? On this ventral horn cells, the ventral motor neuron, right? Good. Where does the corticobulbar end? Cranial nerve motor nuclei. Very good. Just stick a pin right there so everybody can get that. The next question is going to be, which cranial nerve motor nuclei are we talking about? Answer is what? All of them. In other words, all of the cranial nerve, except which ones do have any motor nucleus?
1, 2,
and 8. 1, 2, and 8. So the corticobulbar end on cranial nerve, 9 cranial nerve, just except 1, 2, and 8. Now what do these cranial nerves do? Control the musculature of the head region. So these 9 cranial nerves control what? Muscles of mastication, muscles of facial expression, extraocular muscles, muscles of larynx, pharynx, soft palate, tongue. Exactly. You get that? That's the corticobulbar pathway. Everybody get that? Good. So the descending fibers passing through the genu are corticobulbar. And since you tell me it's a motor pathway, it means that we can find the brain, or we can say this is the part it's coming from, and that part is the what? Precentral gyrus. But you can go further than that and specify which part of the precentral gyrus, and which part is it?
The lower part.
Yeah.
Head and neck.
Yeah, the part where the motor homunculus is head is located right down here.
Yeah.
You get that? And then the rest of it now is cortical what? Spinal. Good. Very good. You get that, Richard? Oh, okay.
I have a question. They're saying that the corticospinal receives fibers from the postcentral.
Yes, true. That's true.
Why?
Because some
Well, first of all, yeah. So first of all, let me just tell you something, right? So when we look at the central sulcus, you can open it and peek down in there. That central sulcus separates precentral gyrus from postcentral, right? And we think that is just on the surface alone is the precentral gyrus.
Oh,
But
there's
there's some part of it down in the gully there,
Or something.
between the two, right? But guess what? Only a third of the corticospinal tract comes from the precentral gyrus. Only 1/3. So although we say it's the primary motor cortex, we're correct. But the one more third comes from postcentral, and the other third comes from premotor, supplementary motor area, and so on, right? So it's 3/3. One from precentral, one from the other motor areas, and the other third from the postcentral gyrus. And of course, those sensory fibers from the postcentral influence the motor pathway too. You get me? So when we do it, you'll see how the postcentral gyrus, those sensory neurons, can influence the motor pathway. Alright, so that's the descending fibers passing through the genu, or what? Corticobulbar. What about the ascending fibers now, passing through the genu? Again, those ascending fibers are coming from the where? Thalamus and going to the cortex. We want to know now which thalamic nucleus they're coming from. But we know at least one thalamic nucleus they're not coming from, which is the anterior nucleus. We know they're not coming from the medial dorsal either. Are they coming from MGB? Are they coming from MGB? No, why? Because MGB is for what? Sound, hearing. Are they coming from LGB? No, that's for vision. So we know 4 nucleus they're not coming from, right? So where are they coming from?
Sir, no, that's not sensory.
Garbage.
Sensory.
Garbage. They're coming from VA and VL. Very good, thank you. VA and VL. Now you have to find a way to get that in your head. Everybody? So the ascending fibers passing through the genu of the internal capsule are coming from the thalamus, specifically from the ventral anterior nucleus and the ventrolateral nucleus of the thalamus. Now let's look on these 2 thalamic nuclei. play in a little more detail, right? To see if we can find anything that can help us now to keep it in our head. I don't know if you remember when I was telling you about dentatorubrathalamic. I told you that end in the what? VA and VL of thalamus. Specifically VL. Okay? So the dentatorubrathalamic ends mainly in VL, but also in VA to a lesser extent. What else ends there? Interpositor rubrathalamic. Good. So in other words, we know that the cerebellum projects to VA and VL of thalamus, but mainly VL, right? Good. So the VL of thalamus gets input from the cerebellum, both from the what? Spinocerebellum and the pontocerebellum. You get it? Remember the dentatorubrathalamic coming from pontocerebellum? And that cerebellum deals with what? One word, 2 words, 3 words. Synergy of movement. Good. So that pathway, dentatorubrathalamic going to VL, has to do with synergy. What the one from interpositor rubrathalamic concerned with what?
Tone.
Posture,
Gait.
tone, and gait. Good. Good. So, remember now, because they're coming from cerebellum, what it means is that thalamin nucleus, VL, is a what? Motor nucleus. You get me? Just like how we said the anterior nucleus was a limbic nucleus, VL is a motor nucleus, and so is VA. But VA now get most of its input from where? Basal ganglia. Thank you. Basal ganglia. Particularly from where? Globus pallidus interna and substantia nigra. Remember I told you substantia nigra is a what? Displaced part of the globus pallidus interna. Good. So let me say it. No, I'm going a little too fast. Some people.
Yes.
But we said VA and VL receive input from the cerebellum. Most of these input from the cerebellum, however, only a little bit go to VA. Most of them go to VL. Which part of the cerebellum are we talking? Ponto and spinocerebellum. The ponto give rise to which pathway? Dentatorubrathalamic. And those are going straight to VL of thalamus. Although a little bit go to VA, right? And the interpositor rubrathalamic that's coming from spinocerebellum goes to VL as well. And a little bit go to VA. So what we're saying therefore, since VL has all of this connection with the cerebellum, you can tell yourself that VL is a motor part of the thalamus, okay? Now VA guys get input too from the cerebellum, these same pathways, but most of the input come from basal ganglia, particularly the globus pallidus what? Interna. Good. Well, we know that substantia nigra is a part of the globus pallidus interna, so we don't have to say it again.
Do you have to specify like the pathway to come after the target?
Yes, we can specify that, but I'm going to tell you that when we do it.
So-
So we actually do cerebellum as a topic, right? Cool. So let's move on now. Don't worry about that. Don't worry about that. All right. So now, guys, if somebody give you a MRI or whatever it is, and when you look on it, you see a lesion in the genu, and the consultant said, "That's a lesion in the genu there." The consultant tells it's a lesion, and then he will say, "Now, what do you expect to see, to find in this patient? What are the deficits? How would you describe?" So just look on the pathways and then deal with them one-on-one. So let's talk, if you have a lesion in the genu, they're going to destroy the things that pass through it, right? So let's talk about the descending ones that pass through. Those will be destroyed. So the patient will have what?
Just no movement of the facial muscles.
When you say facial muscles, when you say facial muscles, you're talking about muscles of facial expression? Huh?
Yeah.
Hello?
It's muscle.
Yes, so those are facial muscles then, so muscles of the head region. I like that better.
Alright,
You
yes,
know, it
exactly.
conveys a better thing. So no, don't say no movement either. That sounds like a man on the street talking. What you must say is contralateral weakness of the musculature of the head region, and it's contralateral. So make a note of that, and we're going to explain that at some point. Okay? So if you have a lesion in the genu, if you're going to have contralateral weakness of the musculature of the head region. That means you're going to have weakness of the muscles of facial expression, muscles of mastication, blah, 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 pharynx, larynx, whatever, whatever, right?
Where did that cross there?
They cross in the brainstem itself, okay? Crossing occur in the brainstem.
Is there something special about the facial nerve? 'Cause
Yes, yes. So I'm going to talk about all of that. And in fact, when you go to the clinics, it's the facial nerve they use. When they're talking about corticobulbar pathway and paralysis, they use the facial nerve, because that one is simpler. Right? So we're going to talk about that. Yes, and then what else will happen now? What other deficit that man will have?
We're going to have problems with synergy of movement.
Exactly. So you're going to have decomposition of movement, right? Which is the same thing as a desynergy. And what else? Problem with posture, tone, and gait. Very good. And what else? The last one now. So what you have told me.
Or the basal ganglia.
Exactly.
So if you have like issues with.
Yes, so say it.
Resting.
You may have Parkinson-like syndrome.
Parkinson-like.
Very good. Very good. See? You work it out. And if you want to be even more precise, because remember, there's not everybody with a basal ganglia lesion of Parkinson's disease. So you can say the patient will have dyskinesia. And then that encompasses everything. Right? But good, good. So this is how I want you to look on this thing. This is how you must treat this thing. Later on now, when you do the blood supply, we're going to tell you which specific vessels supply the genu. So if somebody comes and says, this patient has an infarct in the vessel that supplies the genu, what are some of the deficits the patient will have? And it's the same thing. Right? Okay? If the person get a stroke and it affects the blood vessel, same thing. If you have a tumor in there, same thing. Somebody take a big stone and lick him in the head, see, and it affects those vessels, same thing. Right? Alright. So we move from the genu now. I will look where I put the pin. Where is that? It's in the posterior limb now. The posterior limb. Alright? Everybody? Daniel? Posterior limb. Lisa? You can say? Okay, so what are the descending fibers passing through the posterior limb? Richard?
So, occipital pontine fibers.
What that mean? I don't know.
You want to do this? Cortical pontine fibers.
Good, good. So hear this now. Remember now we said that the frontopontine passed through the anterior limb, right? But what Richard should say is that all the other pontine fibers pass through the posterior limb, descends through the posterior limb. So the parietal-pontine, temporal-pontine, occipital-pontine. And as a matter of fact, even some of the frontopontines pass through the posterior limb as well, right? So you're going to say the majority of the corticopontine fibers pass through the posterior limb. Okay? You get that? Now since we're on the corticopontine, let me ask you now, these corticopontine fibers, what are they concerned with? What are they concerned with? Exactly. Everybody hear that? The corticopontine pathway, guys, all of them, frontopontine, parietal, all of them, concerned with synergy of movement. And let me just remind you again how this thing is brought about. So remember now, it's the cerebellum that causes synergy, right? So what happens? From you contemplate doing something, from you say to yourself, you know what? Let me go outside and drink some water. That involves me walking outside. Or maybe pick up this thing. Any motor task that you conceive of. The cortex, which is where conception occurs, thought. The cortex quickly sends information that, you know what, Solomon wants to pick up that thing. And it goes straight to the pons and tell the pontine nuclei, go tell the cerebellum that Solomon wants to pick up that. And those transverse pontine fibers quickly go over and tell the cerebellum. Cerebellum wave its magic wand, synergize it by giving rise to the dental to rubothalamic pathway to influence the corticospinal tract. And then now, when I execute the movement, it is synergized.
So what I don't understand though, sir, you said that cortex itself goes to the pontine nuclei. Right? You said from you decide and conceive.
Yes.
The primary decisive place is the frontal lobe. So I understand the frontal pontine.
What do you mean the primary decisive place?
Primary is a decision making center. Is it frontal lobe?
Yeah, but remember now, we're not talking about executing the movement yet, you know. We're just talking about just the thought of doing something. You know, so the only function of this wide area of cortex, all of them, is just to tell the pawns that Solomon is thinking of moving. It's not to make Solomon move. Corticopontine can't make me move, right? Corticopontine just a little man that go give a message to somebody to say Solomon is moving. What is going to make me move is corticospinal tract. But if the cerebellum don't do something to this corticospinal tract, when I move, I'm not going to move in a synergized way. I'm going to still move because nothing wrong with the corticospinal tract. Just that it won't be synergized. I'll be moving in a puppet-like manner. So there will be decomposition of movement, right? You get that? All right. So we're moving on now. So we say most of the corticopontine descends through the posterior limb, and even some of those that descended through the anterior limb, which are the frontopontine ones, some of those descend through posterior limb as well, right? What else descends through the posterior limb? Corticospinal, and almost all of it, right? So posterior limb of the internal capsule is the domain of the corticospinal tract. Once upon a time when I used to teach years ago here, I used to tell people that the upper part of corticospinal traveled through the genio, which is true, but that just complicates life. Oh, the booting. Yeah, but that's just complicated things. I have to explain too much. I just forget about that and say, okay, most of it passed through the what? Posterior limb. Everybody get that? Good. Is there anything else passing through the posterior limb? I mean, descending through the posterior limb? Yeah, you can say rubrospinal and those things, right? Those other smaller pathways. But the major one, corticopontine and corticospinal. Good.
So you just said a
Rubrospinal.
I have no clue where we are.
Yeah, don't worry about that. We talk about that. Rubrospinal is a part when we get to cerebellum.
Isn't the red nucleus a bit below the
That's an important.
Isn't the red nucleus below the internal capsule?
So yes, the red nucleus. Remember now, rubrospinal. If you look on that, we call it now, that cross section of the spinal cord, and we say lateral corticospinal tract in the lateral funiculus. Rubrospinal is right beside it, right? But what happens at the rubrospinal pathway, and so rubrospinal pathway, rubro-olivary, olivorubral, corticorubral, all of those pathways travel in the same bundle of fibers that we call the what? Central tegmental tract, right? So you know, so sometimes people just say the rubrospinal descends through the posterior limb as well. Don't worry about it. Reticulospinal descends through there too. All right, but forget about that. The main ones is what? Spinal and corticopontine. All right. What about the ascending fibers now? Passing through the posterior limb. So yes. So give me a more general answer that will encompass everything. The ascending sensory systems. All right? You agree?
Yes.
Good. So the ascending sensory systems ascend through the posterior limb. Then now I'm going to say, which systems are you talking about? I said dorsal column and spinothalamic. Very good. Everybody get that? Get that, Richard? Very good. Now again, later on we're going to look on the blood supply to the internal capsule, and so we can approach the discussion from another angle. Somebody asks an infarct in a vessel will cause what, and we can talk about it, right? Okay, so that's the internal capsule. We've talked about the anterior limb, genu, posterior limb. Is there any other part of the internal capsule?
Yeah.
Yes. What?
The reticulum.
Retrolentiform and sublentiform part. Good. Yeah. Yeah. Everybody write this down. Oh. What's that? Why are you marking on the book? Oh, sorry. It's right. I'm just teasing them. Where's that now? Yeah, don't worry about that. She's asking me where is field 8 of foreign. So that's when we do what? Basal ganglia. On the basal ganglia, right? Don't worry about that. Why you write down these things we've been talking about? Okay. Alright, so the internal capsule has a sublentiform part. What travels through the sublentiform part of the internal capsule? Richard? Yeah, auditory information, yeah. Good. And remember, since it's internal, that is ascending too, right? Give me a better name for what passes through the sublentiform part. What passes through this? Give me a better name. They call it auditory radiation.
Oh, yeah.
Yes, auditory radiation. That's what you must write. And of course, that's an ascending pathway, which means that what? Coming from the thalamus and going to the cortex. So you see, once we keep, right, exactly. So once we keep to the theme, then we can work everything out. So that sublentiform part transmit auditory fibers, and we call it the what? Auditory radiation. And if it's coming from the thalamus, we know it's not coming from VA, we know it's not coming from VL, we know it's not coming from the anterior nucleus. Which nucleus is it coming from? MGB. Good. And if it's coming from MGB, I'm going to ask my friend something. Where is it going? You know, you see, we have to pressure ourselves to start to think about it and stop telling ourselves that we don't know, because we know. No. So if it's coming from the MGB, it must be going to the what? Primary auditory cortex, which is what? HLs. Yeah. Right? Tell yourself that. HL. You get me, deal?
Yeah.
Good. What about the retrolentiform part? Now him say MGB music. He used that. That help him. Now I use LGB light. Right? And retrolentiform retina. That's what I use. Retina, right? So what is the pathway that travels through the retrolentiform part called? You can call it optic radiation, or you can call it what? Since it's coming from the lateral geniculate body and going to the calcarine sulcus, you call it the geniculocalcarine tract. That's the visual pathway, right? Geniculocalcarine tract. You agree? Geniculocalcarine tract.
The optic radiation goes to geniculate body.
Huh?
The radiation.
The optic is coming from the LGB and going to the primary visual cortex.
So where did geniculate body and calcarine?
Huh?
Where did they come in?
No, LGB, lateral geniculate body. That's what it's called.
LGB.
No, lateral geniculate body. So we since it's coming from there, we start off with genicular, coming from the lateral geniculate body. Calcarine going to the walls of the calcarine sulcus, right? Alright, so everybody get that? Okay, so we're moving on now, guys. Moving on now. Look here. I want now, let's see. Alright, so come. I'm thinking now, where should I go from here? And let me just relax and don't get ahead of myself too much, right? So I want to say something else. Look at this now, guys. So you see this internal capsule here? Let us talk about those ascending fibers that are coming up in the internal capsule. The ascending fibers. When them come out of the internal capsule, where they want to go? To the cortex, right? Now, so from the internal capsule, how do they get to the cortex? Corona radiata. And the only reason I bring this up, you can have somebody who comes in with a lesion in the corona radiata and have contralateral weakness too. You get that? So it don't have to be in the internal capsule per se. It can be anywhere along the path. It can be in the crus cerebri, it can be in the basilar pons, or it can be in the pyramids, right? Or it can be in the spinal cord. You get that? Alright, so we're moving on. Alright, so let me broaden our discussion now. I'm putting the pin there. So I'm putting the pin there. That's one white pin. And I'm putting another white pin right here. Look, there. Alright, let me take out the pin and I'll put them aside. Yes? So I have two pins. And generally, what can you say? The pins are in two parts of the what? Basal ganglia. Alright? It's in the head of the caudate, and where else it is? In the putamen of the lentiform nucleus, right? Good. So that's that. No, that's that. Don't want you to hurt your hand. So look here now, guys. Give me one term that for everything the pin is in. So sorry, the pin is in there? No, it's not in the corpus striatum. It's in the striatum. For it to qualify to be in the corpus, it must be in the what? Entire lentiform nucleus, including the globus pallidus. Okay? So you can say it's either in the neostriatum or you can just say striatum. Everybody? So what I want you to write now is the striatum is the caudate nucleus plus the putamen. That's the striatum. You get that? So the striatum is caudate nucleus plus putamen. In fact, if I give you a histology slide of the two of them, you can't tell the difference. Two of them look exactly the same. So it's called neostriatum or striatum. However, the corpus striatum now is the caudate nucleus plus the lentiform. That is the caudate nucleus plus putamen and globus pallidus. You get that? Good. Yes. So the corpus striatum is the caudate nucleus plus the lentiform nucleus. And I have to emphasize that the lentiform is putamen plus globus pallidus. Right? So what's the difference between neostriatum and corpus striatum? Neostriatum has no globus pallidus, right? Good. Go on, Claire. Okay, you mean you want to see it? Alright?
So where's the
Don't mash it up.
Separating the,
No, this is
lentiform.
this is not symmetrical. This one is so you can see it on this side.
Okay.
Right? So this little white thing here, see it? Separating this from this, right? And this white thing separate this one from this one. See?
Okay.
Good.
So really, can I try?
Yeah?
So it'd be hair and hair would be the neostriatum?
Yes. Same thing as over there, right? Yeah, so just here and here. But here, 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 and here
Is globus. Okay.
is corpus. Yes, corpus striatum. Okay, good.
Okay, that's on the same side.
We're gone so far. Huh?
How come it's not symmetrical?
Because remember when we hold it for cut it, you know, if I don't cut it, if I don't do it,
Oh, okay.
you know, make a mistake, right?
So you say now the patient.
Yeah, and I don't have any patience. I'm terrible at that. Yeah, so it's now. Yes? So all we're saying this is the caudate, that's the putamen, right? And she was asking me, oh, over here don't look the same. This one don't show the globus pallidus, only the putamen, right? But this one over here now shows the globus pallidus. So this is the putamen, this is the globus pallidus external, that's the globus pallidus internal. You see it? And you see a little white line between them, right?
Sir, how did you know that over here you're looking at the putamen?
You mean the putamen?
Yeah,
You
how
mean
do
this?
you know?
Yeah, because the putamen is the most lateral part of the lentiform nucleus. And it's the putamen is darker than the globus pallidus. In fact, globus pallidus means pale. All right.
So most of the side of the class.
Okay, sorry. Sorry. No, but it's something I showed you earlier. Look. So this is putamen. See that? This is globus pallidus external. This is the internal. And you see a little white line separating the internal from the external, right? And a little white line separating the putamen from the external.
So you have a globus pallidus over here?
Huh? No globus pallidus
just
over there.
putamen
Just the
and
putamen, yeah.
globus, you don't see it.
Yeah, so in other words, yesterday when I was cutting it, I was asking somebody to put their hand so I could size it up, but in the end I had to do it myself.
So it looks like one remarks on this side and then you see the distance.
Yes. All right, so we're moving on now, guys. Ready?
Wait, hold on. This is the internal capsule right there.
Yes. See? So this is the internal capsule. That's the anterior limb, and that's the posterior limb, right?
So there's no journey.
It's just that this anterior limb is as elaborate as this one. So if I put it out here, it look like it's gone into putamen and all that stuff, right? But in other words, this part is the anterior limb, that's the posterior limb. This is the genu right there. But it's not so obvious like this one. See, this one is the obvious bend, right? All right, so guys, let's move on now. Ready?
Yeah. Sir, I have a question. I didn't seem to understand why you're saying that VL is a multinucleus if you're talking about the ascending
So if say the ascending fibers are going, remember ascending fibers go from thalamus to cortex.
Yes.
The reason why I call them ascending, because they're going to the cortex and they're coming out of thalamus. But I was just giving you a little history now about the VA and VL. I was saying that they get input from the cerebellum.
Right.
And since we know cerebellum is a motor part of the brain, so I'm just saying that since it's motor, since the cerebellum is motor and the basal ganglia, you can consider VA and VL as motor nuclei of the thalamus. That's all I was saying.
Okay.
Right?
So they're separate points.
Yeah, but,
Okay.
but when it comes to ascending, the ascending just start from thalamus to cortex. That's why we call it thalamocortical, right? But I was just saying, one way to try to remember it now is to try to see if you can remember where the nuclei in the thalamus get their input from. If we compare that to the thalamocortical coming from the anterior nucleus, we were trying to find some way for you to remember. So we said that the anterior nucleus get input from the mammillary bodies. And so since it's mammillary bodies to anterior nucleus, then it's limbic. So we see the anterior nucleus as a limbic nucleus. That's the way to remember it.
Okay.
And then if you know it's limbic, then you know where it's going. You don't have to swat off that. Going to the limbic cortex, right? And in the same token, you can write this down. I didn't remember to say that. In the same token, guys, those fibers coming from VA and VL, since we already said that those fibers coming from VA and VL were linked to cerebellum and basal ganglia, it means that those fibers are motor, right? And so we know which part of the cortex is going. It's going to the motor cortex. But more specifically, what I want you to write is this. Those thalamocortical that are coming from VA and VL, this is what I want you to write now. They're going to the premotor cortex, supplementary motor cortex, and frontal eye field. That's where they go primarily. And then now, these three motor areas pass them on to the primary motor cortex. I'm going to say it again, just relax. So again, VA and VL of the thalamus projects to the premotor cortex, supplementary motor cortex, and frontal eye field. Okay? And then these areas now in turn pass the information off to the primary motor cortex. Okay? Yes, exactly. So the input from these areas, these other motor areas, helps in the planning and all that stuff of the motor activity. Right? So we're building a house, guys, little by little, right? So, every little thing I tell you, add it on, and we're going to talk about the same thing over and over again. It's just that you now must try to keep the thing in your head. I'm going for you, to help you, we're going to repeat the thing 100 times. All right, so we're moving on now. Moving on, guys. Are you ready?
Sorry.
Good. So we're moving on now. I want everybody to be on the same page. I have to pause. Every time I have to pause. You ready now? All right. So we have talked about, the internal capsule we're seeing there. We have talked about the thalamus, and we have talked about, different aspects of the basal ganglia. Now let's switch our discussion now to some other things. I want everybody to focus on this specimen I have there. Everybody focus on this specimen. Yeah, look, you see our scissors in there now? Yeah. I want to do a minor surgery, yeah, boss? No, this is not a scissors. Look at our scissors. Huh? It's not scissors. Let me see if any scissors in there. Yes, scissors. Alright, so let me just take off this thing. Successful surgery. know why I'm doing this though? If I try to tear it off, the whole thing mash up. Alright guys, come, let's go. Let's go, everybody. So look here. Tell me what's resting on the pin. That's the basilar artery, right? Good, everybody know that. Now that basilar, as you can see, is formed from these two. Which are the vertebral. What are these branches of? Subclavian. Which part? First part. Very good. Now I want you to observe that this, look on that. This is the first branch of the basilar. Yeah, so everybody on this side see? That's the first branch of the basilar. Alright, this is what I was trying to avoid. Now I have to go lift it up and then start from around here. So it's just rough. See that? That's the first branch of the basilar. See it? So it's big, robust. Look on that. That's a big branch of the basilar artery. And I'm telling you, this is the first branch. What you have to do, put that in your pipe and smoke it. Right? That's the first branch of the basilar.
I know who you and the smoking thing.
Right. Smoke a little herb sometimes. So what's that now? What is that, guys?
Ica.
Huh?
Ica.
That's not pica.
That's
Ica. That's Ica. Oh, I think it's a pica. Sorry, man. Sorry, I apologize, sir.
Ica is from vertebrals.
Exactly. So the pica is from the vertebral artery. This is Ica. So which branch come off after Ica? Labyrinthine. Labyrinthine. And then after that, we have pontine branches. Good. Alright, so everybody on the same page. So look here now. That is not what I really wanted to show you. What I really wanted to show you is this. Is these two structures resting on the pin. These two structures. Look on them. Everybody? See them? Alright. Those two structures resting on the pin, those two blood vessels coming off. You see them? Alright. Everybody see that? Yeah, a large one. The large one is the last one, right? Good. So the first one is what? Superior cerebellar, and then the other one now is the posterior cerebral. Do you think this is what I want to show you? No, that's not what I want to show you. Yeah, what I want to show you is this guy here. That. See that? Yeah, that's 3, right? Look on that. That's the oculomotor nerve. You see where it's coming out? Between the superior cerebellar and the posterior cerebral. See it? You see it? Alright, so that's the third nerve. See that? Sabrina, say it now, man.
Yes.
Alright, good.
So you said something else passes between them.
Yes, we soon come to that. Alright. Look on that, Daniel. That's the third nerve. This yellow thing? Third nerve. Look, this is the superior cerebellar, and that's the posterior cerebral, right? And then this is the third nerve, right? Now, guys, you see this part of the artery, the last part is the basilar tip, and we say an aneurysm can occur there. There is a question on past paper 2010.
Which you submitted, right?
Which I submitted, yes. Very good. And it says, an aneurysm in the basilar tip can compress which of the following nerve? What's the answer? Oculomotor nerve. You get that?
So you never put chocolate in the answers, neither though.
Yeah, chocolate was in there. So look here. And look where chocolate is. Look on this. Look on this. See this? See chocolate here? If I'm boom by the thing, I drop out of my hand. I have to hold it. I understand you? So look, that's the what?
That's tiny.
That's, yeah. But, and you know why it's tiny? It only supply one thing. Right? See there? That's the trochlear. You see what I'm seeing? Two vessels, this and this. You see that, miss? So the trochlear nerve also emerges between this and that. See there? But it's too far from the basilar tip. No, sir. You're too light. Come on. And if anything is alcohol, you know, so it will sterilize the dose. Alright, so that's the fourth nerve. Everybody? This is the fourth nerve. Coming from where? This is a strange thing. Where do you think this thing coming from? The dorsal part of the brainstem and coming around the ventral part. Okay? So that's the fourth nerve. See there? The little thread down here. See? And it's coming up between the same two vessels. This vessel and this one.
Yeah,
So superior cerebellar, posterior
So you said
cerebral.
vascular tip is actually.
Is right here. So this is too far from the tip. So an aneurysm here won't affect that. You see that?
I don't see that in between the two.
I mean, see the two same vessels there, look. See, is it this enough? See there? And see the posterior cerebral there?
Come show me that, sir. Come you never see.
See that?
I see it.
Hello.
You see it? You see it, miss? Alright.
Sir.
So,
Sir.
this is the same posterior cerebellar, this is the same posterior cerebral there. So, which
Sir,
nucleus?
Show me how the same two vessels. I never saw them.
Alright, so from up here we see the vessels, right? This is the superior cerebellar, that's the posterior cerebral. See the vessel, the same superior cerebellar here. See there?
Okay.
And see the posterior cerebral there, and see the nerve there.
Alright.
So which nucleus does the fourth nerve? Right, the same thing again? Well, I'm a belly wet up with cadaver juice.
It's just alcohol.
It will sterilize your stomach.
It was sterile.
Alright, so look here now. Which nucleus does the fourth nerve emerge inferior to? No, which nucleus does the fourth nerve? Which nucleus does the first nerve, the fourth nerve, emerge from the brainstem inferior to? Inferior colliculus. Oh, Eddie Joe Westphal coming on this. Oh, Eddie Joe Westphal coming on this. Yeah, it's a good thing I mentioned it. Look here, guys. Alright. Okay, can I tell you something? Everybody listen to this now. Everybody listen to this. Everybody? Remember the third nerve nucleus is in the midbrain, right? At the level of the what? Superior colliculus. The fourth nerve is in the midbrain too at the level of the what? Inferior colliculus. It's in the midbrain at the level of the inferior colliculus. So when it come out of the midbrain, it will come out below the inferior colliculus, right? Oh. Alright, so we can move on. Alright, we can move on now. Alright, so I'm putting this specimen right there for everybody to see. And I'm putting the pin right there. By the way, this is our what? Coronal section, right? Now tell me where the pin is located. Don't say it, I want everybody to see it first. Okay, let me put the pin on the other side so that the other people can see it. Bam. So where are the pink pins located? This is pink? Yeah, pink. Where's pink? Where's the pink pin located? Don't say it. But I need to look. Yes, where are the pink pins located? Come on, you are dog. You're hot. He's hot too. He's hot. Yes, so where are the pins? Sabrina. Where are the pins? No man, come on. We need to conquer this thing.
It's in the internal capsule.
Good, but that's not good enough. It's where?
Let me look again.
Good. So it's in the internal capsule, so that's a start. But specifically it's where? Now what you have to see in this field to know where it is? The thalamus. And where the thalamus is, see there? See the thalamus here? You see that? So that means it's posterior limb. Now what would this be on the other side? Lentiform nucleus. Not true?
Where's the anterior one? Where's the anterior one?
It can't depend. You can't have everything for one coronal section.
She just asked me what's
Huh?
between.
None that she does.
No, man, I asked if it was on that.
I was helping her.
Because look here, it means that this is a section cut right at the back here. So it's one thing at a time, you would say. That's why I say you must put this in the head. Because the horizontal is everything one time. But in the coronal is one thing at a time. So this now, once you say thalamus, it means that you're looking at the posterior limb. And look, once you see thalamus, guys, it means that this is what? Exactly, that's the body of the caudate nucleus. Can't be the head. And it's not the head for two reasons. A, it's not big. Everybody know heads are big, right? Right. Big head, right? And then two now, look here. Once I do, this is a coronal section, you know, that. So once I go through the head, there's no thalamus there. I have to come all the way back here to get thalamus. And once I get thalamus here, I'm not going to get head anymore because the head becomes the body. You get that? Good. So this now is in the body of the caudate nucleus. And where is the body? It's still in the what? Floor of the body of the what? Of the lateral ventricle, yes. It's still in the floor. Remember, the head was in the floor too, but the head was in the anterior horn. All right.
What is this? This is still the
It can't be still the genu. It must be the body of the corpus callosum. All right. So let's move on a little bit now. Now, guys, what would you say the pin is in? Don't say it. I want everybody to see it. Oh, I can probably use this. Yes. So. Where is the pin located, guys? Look. Bam.
Elizabeth,
yes,
you know that.
Where's the pin? Sabrina. No, see the same place. Sabrina.
The other one.
No, man, you. Come. Time going. What is that?
I don't know.
No, man, you know.
Sir.
You know. Look here. You know what this is, right? What is this? Corpus callosum. So which gyrus is immediately above the corpus callosum? Cingulate gyrus. That's the thing. And that's why I say I have to swat out this one. Right? So if I put it up here now, would it be cingulate gyrus? No. So what you have to say? The gyrus must be immediately above the corpus callosum for it to qualify to be cingulate gyrus. Get that? Good. Alright, so we're moving on now. We're moving on, guys. Now what would you say this is? What would you say that is? What would you say this is? Same thing on that side. It's in the temporal horn. That means it's the what? Hippocampus. It's not the prettiest hippocampus in the world, but it's hippocampus. Huh? Yeah, but that's not so good. It's kind of rotten. So let's not use that, right? Okay, moving on now, guys. So we have touched on a couple of things. We want to graduate ourselves now from some of these things. So we're moving on now. Okay, it's hot stuff now. Look on this now. Alright, so I put in the pink pin somewhere, and I'm going to put the green pin somewhere. So green pin and pink pin. Alright, green pin and pink pin. Green pin and pink pin. Seen it already, right? Green pin and pink pin. So Lisa, go and tell us where the pink pin is. Come on, and Daniel, go and tell us where the green pin is. So Lisa, tell us where the pink pin is. Daniel, tell us where the green pin is. Green pin, pink pin. Green pin, pink pin. Alright, everybody. Green pin. This is beautiful. I love it. Take a picture and frame it. So where's the pink pin, Lisa? And Daniel, green pin. Good. Which means that the pink pin is in the internal. Good. Thank you. Everybody see that? Good.
Can you show it again?
Yes, so the pink pin is in the internal, green pin is in the external. And by the way, the white pin, this is white, no? The white pin is in the putamen. See that? So white pin in putamen, green pin in globus pallidus external, and pink pin in the internal. Beautiful. Now there's a reason why we show you the internal separate from the external, because the connections are different. So when we do basal ganglia, we do the afferents and efferents, we're going to talk about these internal and external, you know? All right, moving on now. Moving on, guys. We have to try to deal with several things at one time. And let me tell you, you guys are going to get hot You're cold now, but all of a sudden you're going to wake up one day and you're going to be hot. I promise you. Right? I promise you. Serious. So look here now. Come on. Cerebellum. Look on cerebellum. See that? What is this? Cerebellum. Alright. So look here, guys. I want you to observe that the cerebellum has two surfaces. This surface and this surface. Now this is the superior surface. See that? Trinidad and Tobago. This is the superior surface. Now I want you to also know, observe, that both surfaces have this region here, which we call the midline region. So this is the midline region in the superior surface, and this is the midline region in the what? Inferior surface. The midline regions are also known as the what? Vermis. So what is this? Superior vermis. And this is the inferior vermis.
Is that the same length on both surfaces?
I've measured them. Right? So look here now. Now, what's the difference, guys? The obvious difference is this. The superior vermis is not well demarcated from the lateral parts of the hemisphere, right? However, look on this. The inferior vermis is in a gully. So the inferior vermis is sunken in a depression. That depression is the vallecula. So the inferior vermis is in a gully, right? That gully is called the vallecula. Everybody get that? So if I'm sleeping and you wake me up and say, what is this? I say inferior vermis because I see it in the gully. You get me? Good.
You can sit down in that thing.
You want to sit down in the gully?
It's okay.
All right, good guys. Let's move on now. Everybody? Yeah. The gully, we call it the what? The vallecula. All right, come back again now. Look. We're going back to the superior surface now. Look here. I see a whole heap of lines in the superior surface, and I'm not interested in them. I'm only interested in which one? This one here. That one is the what? Primary fissure. So when on the superior surface, there are several fissures. The only one you're interested in is the primary fissure, which is that one. Okay? That's the primary fissure. See that? Primary fissure, right?
No, I can't.
Yes, one thing at a time.
So why you move from us to go over there?
Because I like those people on this side better. Nothing wrong with that. I'm sure Sabrina doesn't like me. Right? She loves me.
Yeah, but is it
So that's the
well demarcated than the others?
yeah, so one thing at a time. So this is the what? Primary fissure, right? The other one is garbage. Now look what the primary fissure does, guys. It separates this part of the cerebellum from the part below. This part is the anterior lobe, and the part below is the posterior lobe. So that is what you need the primary fissure for. It separates the anterior lobe from the posterior lobe. Very good.
So sir, is it on both surfaces?
Come on, relax, one thing at a time. Give me a chance. All right? Everybody have that? Good. Let's go on the inferior surface now. Bam. We see all kinds of structures there too. All kinds of fissures. But the only fissure we're interested in this surface is this one here. See? That fissure there. What we call it? You call it the dorsal fissure or the posterior fissure.
It's on an angle or it's vertical?
Yes, see it? See it? Good. Now look what it does, guys. It separates, look. It separates this little fluffy part of the cerebellum. Yes, which we call the flocculus. So it separates the flocculus from the rest of the cerebellum. So this dorsolateral sulcus, as they call it sometimes, or posterior lateral sulcus, which is the same dorsal we call it. Some people call it dorsolateral. Look what it does. It separates this little fluffy part, which is called the flocculus, from the rest of the cerebellum. Everybody get that? Yeah? So this dorsolateral sulcus separates this, which is the flocculus, from the rest of the cerebellum. on the inferior surface, right? That's the one you're interested in. You're not interested in anything else. Good. Yes. Sorry about that. So this dorsolateral sulcus, this one,
Earphone.
separates this part of the cerebellum that's called the flocculus from the rest of the cerebellum. All right?
Earphone.
It's a bit.
Yeah, one thing at a time. One thing. We're coming to it.
Why is it dorsal? It looks like
Yeah, don't worry about it. One thing at a time. Right? Okay, good. Everybody get that? Now, other thing to tell you guys is this. So remember we said this was the what? Vermis, right? Now, just 1 to 2 centimeters lateral to the vermis is the what? Paravermal zones. So 1 to 2 centimeters on either side of the vermis is the what? Paravermis. So on either surface, same thing. On either surface, same thing. So that's the vermis. And on either side is the paravermal zones. Good. Do you have that? And then one last thing I want to say before I go into the meat of the matter now is this. I want to, if you notice these 2 little bulges on either side. 2 little bulges. Yes, these 2 bulges on either side. These are the so-called cerebellar tonsils.
That's particularly on the inferior surface.
Yes, only on the superior surface here you don't see them, so they're on the inferior surface. I want you to
Those
notice
are the
something.
things that herniate.
Huh?
Those are the things that herniate.
Yes, yes, so I'm going to talk about it right now. But look here, guys. Also notice that the inferior surface associated with the what? Medulla. See the medulla there? See that? Good. You see any medulla here? No. So once you see medulla, you're in the inferior surface. Right?
So you say it's on either the cerebellar tonsil on either side of the medulla.
Yes, I understand. Good. Now, as this guy was saying, guys, when you have a space-occupying lesion in the brain, or I should say in the cranium, or you have hemorrhage, what happens is that the pressure going to start to build up and increase, right? Now, the skull have a way to deal with that pressure. I don't know if you know, there's a thing called
Hello.
yeah, law.
Kelly Monroe doctrine.
Yeah, Kelly Monroe doctrine, right? So that doctrine starts off with the premise that there's only 3 things in the skull: blood, CSF, and brain. And when the pressure gets high, it can reduce the CSF to go back to normal, or it can reduce the blood, right? But it can't. Nothing else can happen, because remember now, the brain is in this vault that nothing can occur nowhere except what? To relieve the pressure, except through the foramen magnum. So, however, just like in everything else, if that little Kelly Monroe doctrine exceeds its usefulness and the pressure is still going up, then what will happen? The contents of the posterior cranial fossa will start to squeeze through the foramen magnum. Okay? And once it starts to push through the foramen magnum, these 2 tonsils are going to start squeeze off the medulla. Okay? And I don't know if you remember that the medulla has vital respiratory and cardiac centers. So once it reaches a critical mass, expiration right away. Right? The doctrine is no, the doctrine actually, and in fact there's a graph on one of the past papers too. What the doctrine shows is how the body, the brain, the skull can actually adjust itself and reduce the pressure. But if the pressure is still going, it's going to reach a point where it can't do nothing else now, and you're going to have herniation. Right? And once the herniation occurs, death. Before you know it, death. After that is milk and honey and streets of gold. Right?
You're good.
Huh? If you're good? Okay. I guess I'm not going there. But that other place seemed to be much more fun though.
Really?
Yeah man, all kind of fun people going to be there. Bob Marley going to be there, I know.
How you know that?
Most of my friends are going to be there. And I know I'm going to say, hold on, what's Sabrina over there? Alright, so the other thing too guys, topographically, is that pica takes a tortuous course on the tonsils. Okay? So anybody asking anything about the tonsils, tell them that if the contents of the posterior cranial fossa are herniated, then the tonsils can compress the medulla and cause instant death since the vital centers are there. But tell them also that the tonsils are of topographic importance because pica runs on them. Alright, so we're moving on now. So I've given you some basic things, right? Some basic things about the cerebellum. Now, there are 3 ways of looking at the cerebellum. Yes? Write this down, guys. There are 3 ways of dealing with the cerebellum. You can look at the cerebellum in terms of how it developed in the animal kingdom, right? So we call that phylogenicity. So we can look at the cerebellum from its phylogenicity, right? And if we look at that in that way, we're going to come up with three phylogenetic divisions of the cerebellum. Everybody with me? The first cerebellum to appear in the animal kingdom appear in fishes, and that is the archicerebellum. So one of the phylogenetic divisions is the what? Archicerebellum. Archicerebellum. Later on, when the fishes couldn't manage the density in the ocean, some of them came on land, became amphibians and reptiles, right? And those now developed another part of the cerebellum known as the paleocerebellum. So anytime you hear these terms, just think of phylogenetic divisions of the cerebellum. I'm not going to tell you what all of these are, just one step at a time. Yeah?
But I never know about fishes.
Yeah, don't worry about it. That's the difference between us and the Americans, you know. I learn evolution in school, and I don't have to take it as gospel. If them give me a question, I write the essay and get a good mark and move on with my life. In America now, it's a big thing. You're poisoning the kids' mind with this thing, and you have to teach them about creation alongside evolution so they can make a choice. All that garbage. Anyway, come. And then now, guys, later on now, mammals develop the most recent part of the cerebellum now. That's called the neocerebellum. So we have an archae, a paleo, and a new cerebellum called the neocerebellum. Okay? Now, anatomists, what they have found that based on afferents and efferents, they have found that this so-called archicerebellum is identical to the vestibular cerebellum. So the archicerebellum is the same thing as the vestibular cerebellum. Now this archicerebellum, guys, stroke vestibular cerebellum, is the flocculonodular lobe. Floccular. You see the flocculus I showed you just now? So let me stick up it now. And yes. So this little thing that I showed you before, it's much better on some brains than others. Let's see.
What that say? Nasty.
Yeah, this is hemorrhage. Don't worry about it, man. Alright, this is not, oh, good, this is not bad. See how flocculus on this side. Wow, this is beautiful. So easy it is for these things to tear off. Beautiful, guys. This is nice. So look here now. This is the same dorsolateral sulcus we're talking about. We say it separates this thing, the flocculus. See the flocculus there? Nice. Yes, that's the fluffy thing. So this is the flocculus, you see it? All right, let's come over here now. That's the flocculus. See that?
Both pieces here?
Huh?
This is broken.
What?
Both of them are just that one
Isn't that-
piece.
Okay,
What?
so
What?
where is the...
Wait, dog.
Seeing two break.
Hmm?
Right.
What you asking me now?
Seeing this piece and that piece there.
Yeah, man, the whole thing, all this entire thing here.
What's this?
So,
This is the middle cerebellar peduncle.
Okay.
All right?
This thing right here?
Yes, this is the middle cerebellum.
where's the
Remember now,
line?
this is the pons,
Yeah.
and that's the middle cerebellar peduncle, right? But this, see the line we're talking about, see it here?
Yeah.
This is the dorsolateral sulcus. And this thing here is the flocculus. See it?
Oh, so that
Yes.
tear there is just an accident?
Yeah. Yeah, one thing at a time. So this is the flocculus, right? Everybody? That's the flocculus. Okay? Flocculus.
Same thing as
No, flocculus.
Say one more time over here when you finish.
Good. Where's the now?
She never saw.
That's the flocculus, right?
So what's that?
Yeah, one thing at a time.
Okay. One thing.
One thing at a time. That's
And
the
this is
flocculus.
the dorsal,
Huh?
the dorsal fissure?
Yeah, this is the dorsolateral sulcus. This one here, right?
Okay.
Okay, good. Now look here now, guys. I have to clean up this mess here. So let me go back to this now. Look. So you see this inferior vermis here? See that inferior vermis? The most top part of it, the most top part, way up here, the most top part of it is known as the nodule. Alright? The most, what they call the most rostral part of it is this part down here is the most caudal part, and this part of the top where the pin is in is the nodule. So what you must write down, the most rostral part of the inferior vermis is the what? Nodule. So the flocculus plus the nodule is the flocculo-nodular lobe. Yes, that's the nodule there. See? The most rostral part of the inferior vermis, right? Good. So the most rostral part of the inferior vermis is the what? Nodule. Lisa, see it? Good. So this is the most caudal part, and this is the most top part, right? Which is the nodule.
And you said nodule plus.
So the nodule plus the flocculus, guys, is the what? Flocculo-nodular lobe. And I want you to make a note now that this is the first time we hear we're talking about. This is one of the lobes of the cerebellum now, the flocculo-nodular lobe. So look here, you're going to write. Remember, I just told you based on connection, the archicerebellum is exactly the same thing as the vestibular cerebellum, which we now call the what? Flocculo-nodular lobe. So the vestibular cerebellum equals the archicerebellum equals the flocculo-nodular lobe. But I want you to make a note of this lobe that I just mentioned. Then now, look at this now, guys. So when we're finished with this discussion, you should have no cobwebs left. Now look at this now. So we say reptiles and amphibians now develop this thing that we call the what? Paleocerebellum. Look what the paleocerebellum is now. Paleocerebellum is the superior vermis in the anterior lobe. So look here, this is the entire superior vermis. And notice there's a little part in the posterior lobe, but most of it resides in the anterior lobe, right? So the paleocerebellum is the superior vermis in the anterior lobe, and the inferior vermis in the posterior lobe. You get that? So remember, now all of this is inferior vermis, from the nodule go all the way down. But this part in the posterior lobe, just this part alone, plus the superior vermis in the anterior lobe equal to what? Paleocerebellum. So you're going to write paleocerebellum equals superior vermis in the anterior lobe plus the inferior vermis in the posterior lobe. So, yes, so all of this is the inferior vermis there, and just this part that my little finger is on is in the posterior lobe, right? So, what do reptiles and amphibians have? They have a flocculo-nodular lobe plus a paleocerebellum, right? Which is superior vermis in anterior lobe, inferior vermis in posterior lobe. And then now, later, oh, yes, so we said this, we already said this is the superior vermis in the anterior lobe, right? This is the entire thing is the superior vermis, but notice most of it is in the anterior lobe, just this little part is left, and that's in the posterior lobe. But the paleo is superior vermis in the anterior lobe, and the inferior vermis in the posterior lobe, which is this little part here, which is just this little part at the bottom here, right?
So
You get
so
that?
when you were talking about the nodule, then that would be the inferior vermis and the anterior.
No, that would be the most superior part of the inferior vermis. Let's leave it at that. So this is all of this is inferior vermis, and it's just the superior part here. Remember, the anterior lobe is mostly seen on the superior surface, right? You can, but it's usually they don't use the inferior. So all of these things are complicated. You really can't point it out well. But so the superior surface is used. All right. So look here now. Then now in mammals now, we say this lateral part of the hemisphere evolved, and so we call it mammals develop this so-called neocerebellum. And look what the neocerebellum is. It's the lateral part of the hemisphere plus the superior vermis in the posterior lobe. Okay? So, neocerebellum, lateral parts of the hemisphere, plus superior vermis in the posterior lobe. That's what the neocerebellum is. Good. Posterior lobe. So, neocerebellum, lateral parts of the hemisphere, okay? Plus the superior vermis in the posterior lobe. Everybody get that? All right, let's move on now, guys. Listen to this now. Now, listen to this now, guys. Based on connections, remember what we say? Based on connection, archicerebellum is the same thing as vestibular cerebellum. Well, based on connection, the pontocerebellum is the same thing as the neocerebellum, based on connections. Okay? It's the same thing as the neocerebellum, which is the what? Lateral parts of the hemisphere plus the superior vermis in the posterior lobe. Good. So far, based on connection, two parts of the cerebellum, guys. So far, based on connections, two of the phylogenetic parts are identical to two functional parts. So the archae is identical to vestibular cerebellum, neocerebellum identical to pontocerebellum, right? And so now all we have left is spinocerebellum, which is the other functional part. And look what the spinocerebellum is. The spinocerebellum is the paleocerebellum plus the paravermal zones. You get that? So remember, we said paleo was superior vermis in anterior lobe and inferior vermis in the posterior lobe. So that paleocerebellum plus the paravermal zones equals spinocerebellum. But look here, keep your eyes on my.
What do you call it? Show me the paravermal zone.
Remember what I said, this is the vermis, 1 to 2 centimeters lateral to the vermis, right? But look here, if you look at what I have here, 1 to 2 centimeters lateral to most of the paravermal zone seem like it's in, well, some of it in the neo, yes, some of it in the neo, but look here, most of it looks like it's in the anterior lobe. You get that?
Yeah.
Good. So this is what I want you to write down now. So everybody have that. That the spinocerebellum is paleo plus paravermal zones. So we now have three phylogenetic divisions, which is archae, paleo, and neo. And now we have 3 functional divisions: vestibular, spino, and ponto. Now that is what you are interested in as a medical doctor, right? Nobody will ask you about the phylogenetics, but of course that helps you now to understand the anatomy of it, right? But look how I'm going to synthesize this thing even further for you now to make it simpler. Guys, I'm going to synthesize it now for it to be even simpler, right? So we have simplified the archae and said that most of the archae is the what? Floccular nodular lobe. So I can now stick a pin in the flocculus representing the archicerebellum, right? Or the vestibular cerebellum. Good. So I want to be able to stick a pin now somewhere representing neocerebellum or spinocerebellum, right? So look here. Remember I just told you that the neocerebellum is the lateral parts of the hemisphere plus the superior vermis in the posterior lobe. Yeah. Look here. So my hands is in the what? Lateral parts of the hemisphere. So and where exactly would you say my hand is? My 2 thumbs are? Posterior lobe. So for all intents and purposes, you can say the posterior lobe is the neocerebellum. Not true? So look here. Oh, look here. Look, I just told you that the lateral parts of the hemisphere, which is what my hand is on, plus the superior vermis in the posterior lobe is the neocerebellum. But look, this neocerebellum I'm telling you about, it's really the posterior lobe. The only difference is this little part here, right? So for all intents and purposes, when you go in the exam and the man stick a pin here, it's in the posterior lobe, and that's the neocerebellum, right? If you want the whole of it, all of this is neocerebellum. All of that is neocerebellum. See? all of that, and it's posterior lobe.
In the lateral hemisphere?
Hmm?
It's not particularly in the lateral hemisphere.
It's in the lateral hemisphere.
Right.
But what I'm saying, the lateral hemisphere is the posterior lobe. Because look here, what we have left, apart from this that my thumb is on, all we have left is this. So, it's not true. Remember now, you know, this is the central sulcus here. And what we have, the primary fissure, sorry. So look here, right? So all we have, when you look on the primary fissure, all we have is what? Anterior and posterior lobe. We don't have nothing else.
Okay. I thought it was a midline.
No, forget about that midline thing. I'm just trying to find a way to simplify it, right? Because you want, when you go in the exam, when the man stick a pin somewhere, you want to know where the pin is. Okay? So look here, when I stick a pin here, you know where the pin is. Look, I stick a pin here and ask you for the afferents to this. You know it's in the vestibular cerebellum, right? Good. So I want to know now, when you go in the exam and the pin is here, what are you going to tell the examiner? You're going to tell him it's in the anterior lobe, and that is the what? Spinocerebellum. Spinocerebellum. So it's in the midline region plus the paravermal zones, right? That's spinocerebellum. So this is the anterior lobe, and for all intents and purposes, the anterior lobe is the what? Spinocerebellum. Okay? This is in the lateral part of the hemisphere, which is really the posterior lobe. For all intents and purposes, that is what? Pontocerebellum. You get that? So now we have 3 lobes. We have the flocculonodular lobe, which is the vestibular. We have the anterior lobe, which is the spinal. Or we have the posterior lobe, which is the pontocerebellum. Everybody get that? Good. Huh? That's fine. That's fine. You get this though. It's in the flocculus. You get that? And remember, the flocculus plus the nodule is a lobe. Flocculonodular lobe.
The nodule was the most rostral part of the
Inferior vermis. But because I can't point on 2 things one time, and this is bigger than the nodule, this is of the 2 of them, this is the biggest, right? So I can say this is represent most of the vestibular cerebellum. Okay?
So, okay, so you just gave us the 3 things. So
Yes.
ponto, and then when you turn it on, and it's
Right. So we have spina, ponta, and what? Spina, ponta, and vestibular cerebellum. That's what? Functional things that we're interested in. And then now each functional has a phylogenetic name. So the arche is the vestibular, the paleo is the spina, and the neo is the ponto. Right? Good.
And so the ponto is basically in the posterior.
Yeah. Most of it is in the posterior. So that's a good way to look on it, right? And when you read the textbook, that's what the textbook will tell you. Now look here now. What do you think, guys? What do you think the vestibular cerebellum is concerned with?
Sir, I think it have to do with hearing, you know, sir. Coordination.
No, the vestibular cerebellum. Nothing to do with hearing.
Sir, to loud sounds.
No, vestibular cerebellum I'm talking about, you know. It has nothing to do with hearing. The cochlea has to do with hearing.
Sir, but isn't there, that comes through the inferior cerebellar peduncle, vestibular cerebellum.
Yes, so remember now, the inner ear apparatus have 2 things in there. It have the cochlea and it have the vestibular apparatus. The cochlea is for hearing, vestibular apparatus is for balance and coordination, right? And if you think about the fishes, in the sea, in water, one of the main difficulty fishes have is to stay upright because there's this rolling and so on. The same problem airplanes have, right? And so that's why they have these fins now to stabilize them, right? So the vestibular cerebellum is to stabilize the fishes for balance. You get that? Good. So listen to this now. I am telling you that the flocculonodular lobe is for balance and coordination.
Which is the same thing as the vestibular cerebellum.
Yes. Right? So the vestibular cerebellum is for what? Balance and coordination. Now with that in mind, I can now ask you, if it is for balance and coordination, where is the vestibular cerebellum getting most of its input? From the vestibular nerve and nucleus. And I'm going to explain that to you in detail, but just write that down. You get that? No, that's not a difficulty for us at all, because we know the vestibular apparatus have the semicircular canals, the utricle, and the saccule.
Sir, we didn't know that. But since,
Oh, you didn't? You never learn it from kid?
sir, stop it, sir.
All right, just write that down. So guys, Okay, write this down now. So again, the vestibule of the inner ear has 3 semicircular canals at right angles to each other. Yes? Yes, have these 3 semicircular canals at right angles to each other. And they are strategically organized like that, guys, so that no matter how you move your head, they can pick up the vibration, right? They can pick up the change in position of head movement. There's 1 semicircular canal for any way you move your head, okay? And of course, you don't know it, but even when you close your eyes, you are aware of your head in space, okay? Yeah, just accept that.
Alright, yeah.
You might not be aware of your head in space. All right, anyway, so that's one thing, right? So the semicircular canals are for that head movement. And it doesn't matter if it's linear head movement, rotational head movement, or even when the head is static. The vestibular nerves still send the information off to the cerebellum to tell the cerebellum that the head is static, right? So the head now, head position, right? Signals coming from the vestibule tell the cerebellum about your head position. Static head position, rotational movement, and linear movement. And again, it is the vestibular nerve that conveys the information to the cerebellum. Everybody get that? So what you can write now is raw data from the vestibular apparatus. Raw data from the vestibular apparatus gets to the vestibular cerebellum via the vestibular nerve. And we're going to go through that several times with you. Raw data from the vestibular nerve. What is that? The vestibular apparatus gets to the vestibular cerebellum via the vestibular nerve, right? You have that? Now guess what? Some of this information bypasses the vestibular cerebellum and goes to the vestibular nucleus. Okay? Oh Lord, we have to say everything more than one time. Some of this information from the vestibular apparatus bypasses the vestibular cerebellum. So the vestibular nerve, the statement I made, carries raw data to the vestibular cerebellum, right? But some of this, yes, but some of this data in the vestibular nerve goes to the vestibular nucleus instead. And again, guys, when we do cerebellum, we'll go through that. We'll do it again in details. So some of this data, guys, some of this data bypasses the cerebellum and goes straight to the vestibular nucleus and relays there. And then the vestibular nucleus now conveys the information to the vestibular cerebellum. Okay? Let me give you a diagram, because that is not complicated. I don't know about it blinking and all them things. Sorry. Alright, so look here now. Everybody, if this is the midline, and let us say this is one vestibular cerebellum. Look, if that is one floccular nodular lobe, I could have drawn a box or a circle. I choose to draw it this way, right? What I'm saying to you is this. What I'm saying to you, look, this is the vestibular nerve. I would say the vestibular nerve carries data from the vestibular apparatus directly to the vestibular cerebellum, okay? So when we talk about afferents to the vestibular cerebellum, that's what you're going to tell them, vestibular nerve, okay? Now this is a nucleus in the brain stem called the vestibular nucleus. This is a nucleus in the brain stem called the vestibular nucleus. It has several subnuclei. So what I'm saying now, some of this information in the vestibular nerve don't go to the cerebellum, it goes straight to the vestibular nucleus and relays. And then now the vestibular nucleus now process the information and send it over back to the vestibular cerebellum. So we said the two inputs that go to the vestibular cerebellum, One of them come from the vestibular nerve, the other one from the vestibular nucleus. So when I gave you the mnemonic, I gave a mnemonic called VISCOR. V-I-S-C-O-R. We said the I was for the inferior cerebellar peduncle. So these are the pathways that enter the cerebellum through the inferior peduncle. And the V is the biggest contingent of fibers from the vestibular nerve and the vestibular nucleus. Right? When we do this part of the cerebellum in detail, you're going to see how the vestibular cerebellum is able to cause balance, prevent us from falling over, right? When we do the details of it. But for now, just suffice it to say, the two main afferents to the vestibular cerebellum come from the vestibular nerve and vestibular what? Nucleus. All right, moving on now. So look here, guys. Let me put the pin now. Look, I'm putting the pin now in the posterior lobe, and that's what we call in what? Neocerebellum or pontocerebellum. So just as though we talk about the main input to the vestibular cerebellum, we want now the main input to the pontocerebellum. And what's the main input? From the pons, right? So what's the pathway called? Pontocerebellar fibers, or you can say the transverse pontine fibers. What are these fibers for? What are they for? What are this pathway for? Synergy of movement. Just like what that one is for balance, right? The afferents to the pontocerebellum is for synergy of movement. Everybody get that? Good. So anybody ask you for the input to the neocerebellum, you tell them transverse pontine fibers, or you can say pontocerebellar fibers. You get that? Good. So we're trying to build a house and we're taking our time. Because we have how much months to do it, to build this house? 4 months? When is the exam? Not me.
April. Last week of April, sir.
Come on, you can't compare UG to Neuro. You can't read UG in 1 week. Anyway, come, let's go. And by the way, guys, if you want to get good help with UG, it's in Najeeb. I'm hot with kidney. It's the hottest thing ever with kidney, I'm telling you. The only thing initially, it take long to develop a point.
Yeah.
But if you persist and take some notes, rewind until you have a little book. I have a little book with some renal physiology.
Let me see, no
Nobody
sir.
can touch me with that.
Let me get
Wicked,
something.
from Najeeb. That man is something else. Not telling a lie. Everything, all histology. Not as good as me with histology. Alright, so look here now. What's the afferents to the pontocerebellum, guys? Transverse pontine fibers. What is the pontocerebellum for? Synergy of movement. Now, what if the pin were here though, in the spinocerebellum? What would you say is the main input to spinocerebellum? Let me ask Sabrina again. I know she thinks I bother her too much, but when I'm finished with her, you know what she's going to become? Neurologist. I am telling you. She wants to do pediatrics, but she's going to do neurology. I'm telling you what you want to do. You don't know what you want. So look here now. Guys, what is the input to the spinocerebellum? Good, so the input coming from the spinal cord. That's the first thing you must start off with, and that will kind of tingle your memory a little bit. And then now you say dorsal and ventral spinocerebellar pathway. Yeah, hold on one sec. We don't want to eat the whole bread one time, one slice at a time. With a little. I don't believe it's not butter. No man, I can't believe it's not butter.
Uncle was the best.
Yeah, it's the best for clogging up the coronary artery. Can't get better than that. Alright, so yes, so listen to me now, guys. The ventral spinocerebellar pathway, how do they get to the cerebellum? Which peduncle? Good. How you know? Mr. Larry Song. Thank you. you see that viscor, look, you see the S? It has a subscript D. That's dorsal spinal cerebellar. So that travels through the inferior peduncle. Don't forget these things, you know. I try everything. When I wake up in the mornings, I say, let me find another way to impart this thing. I try my best, you know. How much credit I get? None. Zero. Zero credit. Zero credit. Huh? Who that? Yeah, that's because she's my friend. she's biased. Alright, come. Move on. Travels through the superior peduncle. Yeah, inferior peduncle. Right? So I'm in the hospital now. One of my consultants, when I look, I'm a new consultant, I'm doing senior clerkship in medicine. When I was doing it, one of my consultants come, when I hear she roughing up the student, I look over through my eye. This girl, when I used to teach her in second year, I used to have summer classes, do a lot of spotters, and she come to me and says, sir, I want to come to your spotters, but parents can't afford for me to stay on hall in the summer, so I have to go back to Balaclava or wherever she come from. So I said, no man, I will help you. So I'll go up to the bursary and I speak to the budget controller and ask her if I can get her a summer job for me. She get the summer job, and so she will come to my class. Right? So she now will tell you I'm a nice guy. Right? But those are the things I used to do. I just want to lead into something. No, I want you to know that I'm a nice guy.
So I said my facilitator talks about him when he said he didn't get any credit. So that's where he dropped it.
Right? So I want you to know it's not only you think I'm a nice guy, and others think so too. Alright guys, now good. So we have two inputs so far to spinal cerebellar, dorsal and ventral. Somebody behind me was saying what else? Cuneo-cerebellar. Cuneo-cerebellar, right? Okay, so now we have three pathways to the cerebellum, and guess what? They're all coming from the spinal cord, guys. Okay? So let me ask you a question. Where is the dorsal spinal cerebellar pathway? Which part of the spinal cord is projected from? The dorsal, right? Yes, Clark's column. As if everybody know what that is. Right? But since he hit the nail on the head, it's Clark's column, right? So most people say from where? So see what? T3 or T4? You sure about that? What you say? You know, extend, the lumbar. Of course, L3, L4. Yeah. So look here. What some people say for the dorsal, it's mid-thoracic down to the big toe, right?
Yes.
Right? So some people say it's from T6 downwards.
Yeah.
Right. So we don't know where you get your information from. Yeah. So mid-thoracic region down to the big toe. Okay? We're talking about the dorsal spinal cerebellar pathway. So we remember we say it's coming from the spinal cord, right? So I remember the spinal cord is a cervical all the way down to lumbar. So we're asking which part of the spinal cord is this dorsal spinal cerebellar coming from? And what I'm saying is coming from the mid-thoracic region, so that's about T6 downwards. Okay? That's where the yes, it's the same thing as Clark's column. So that's right. Remember, we're not doing cerebellum now. This is an introduction. We're going into the details soon.
So you're saying from T6 down?
From mid-thoracic down, right? So it's, remember the thoracic part of the spinal cord are from T1 to T12. That's true. And it's from mid-thoracic, so it's 6 to 12. Right? Good.
So, sir, when I say that Clark's nucleus is from C8 to L2, ignore that?
No, don't ignore it. Don't ignore it. But you can say by and large, most of the dorsal spinal cerebellar are coming from Clark's column.
Oh,
How
okay,
do you think
okay.
about it?
Yeah, I got it.
Right. Remember now, it's not, some people just include, some people include C8. Just to say, well, I think it's a little higher than that. Right? So, but there are some anatomists who steadfastly hold that is mid-thoracic down. Right? So nobody's going to kill you if you say something about T6 down or whatever. following figure. Not a measurement there. Alright. And this Clark's column is the same thing as the nucleus dorsalis, for those who want to know. Right?
No, thoracic.
Same thing.
No, it's
Same
also
thing.
dorsalis.
Same thing, man. Go on to you, man.
The reason I say we're not trying to pull
Yeah,
one
I
of
understand.
a long time.
Alright, so let's move on now. Good. So it's a Q. Yeah, and by the way, guys, these ventral, dorsal, and cuneo cerebellar pathways, which modalities you think is being transmitted to the cerebellum? Which modalities you think is being transmitted to the cerebellum?
Unconscious proprioception.
Is it conscious or unconscious? Unconscious proprioception. That's all? That's all, guys? It can't be just unconscious proprioception. What about light touch and pressure? It's the same, basically the same thing that runs in the dorsal column, you know. It's just that this is unconscious information. Not true? And that is why, look here, that is why when somebody has a dorsal column lesion, right, and they have to look on them foot to know where their legs are in space, you have to do a series of tests to see if this person has a cerebral cortex lesion or a spinal cord lesion or a cerebellar lesion.
So that makes into the Romberg.
Yeah, exactly. So good. So the Romberg sign, everybody, you know about Romberg sign. This is when the patient walks and stomps on the ground and looks to see where his feet are. So that tells you when you say, hold on, that guy is displaying Romberg sign. That means he may have a dorsal column lesion or a cerebellar lesion. So you have to do a series of tests now to differentiate whether or not it's a cerebellar or a dorsal column lesion he has. You get me? And we're going to talk about those. But I'm just whetting your appetite, and then as we come back the next time now, we formally go through the cerebellum, right? Hopefully by then, because of this discussion, it won't be hard for me. All right, so we're moving on now. So apart from, yes, so if I were to ask, you know, this dorsal spinocerebellar, this cuneo-cerebellar, this ventral spinocerebellar, which receptors are involved in each of these pathways? Because it's the same receptors. Golgi tendon organs, muscle spindles, and joint capsules. Those are transmitting what? Proprioception. But we said they are pressure too. So where is that coming from? Pacinian corpuscles. Pacinian. No, Pacinian.
2 points.
Mycinus is 2-point touch.
So I always mix them up.
You need to stop doing that. Okay, so we're moving on now. Moving on now, guys. Anything else? Anything else? Any more? Any more afferents? Any more afferents to the spinocerebellum? Any more afferents? Yes. Olivocerebellar. Olivo. Well, one thing at a time. Let's dissect this olivo thing. So where is this olivocerebellar coming from? Tell me specifically, for 100 marks, give me the specific answer. Inferior cerebellar, inferior what? Olive, 0. I said specific. Contralateral, inferior, olivary nucleus, contralateral. I remember we said, all parts of the cerebellum get that input, all parts. So now we have 4 inputs to the spinocerebellum, right? Do you have any more inputs to the spinocerebellum? The reticulocerebellar pathways. If you read the bar called this reticulocerebellar pathway pre-cerebellar nuclei. You see that?
No, sir.
Good. And they're primarily coming from which reticular nuclei? Lateral and paramedian nucleus. Lateral and paramedian nucleus. Anything else? I want to tell you the bar also include all the sensory nuclei of the trigeminal nerve. Also projects to the spinocerebellum. And it makes sense. It makes sense. Because remember now, guys, proprioception don't only come from the body, it come from the head too. Which part of the head? TM joint. TM joint. And the muscles of mastication. That's true. If it's a muscle spindles, right?
Yeah.
Muscles of mastication. Okay. Remember now, if I strike a patella, not a patella, tuning fork, and put it on your mastoid process, you can feel the vibration, right? That means the trigeminal also is responsible for transmission of vibration sense too. Not true? So we have all those receptors are there. Ascenian corpuscles are in the head too, right? Are associated with the TM joint too. You get that? Very good. So we're moving on now. We're moving on, guys. We're moving on. So we have basically looked at the inputs to most of the different parts of the cerebellum, right? Now another thing I want to tell you is this. If you have a midline, not a midline, a lateral lobe lesion of the cerebellum, lateral lobe lesion, right? Remember we said this part of the cerebellum deals with synergy, right? So if you have a lesion in the lateral part of the cerebellum, what do you think will be the major thing you're going to notice in the patient? Well, yes, you're going to notice decomposition of movement, right? Decomposition.
What does that mean?
Yes, I'm going to tell you now. I need to tell you. So, decomposition of movement. And what it really means is this. Remember, one of the importance of the neo/ponta cerebellum is for smooth, coordinated movement, right? What it means is that each movement is going to involve several joints, and one group of muscles is going to relax while a different group is contracting. And that's how you get a smooth movement. If the two antagonistic groups are contracting at the same time, you're not going to get a useful movement. So one of the functions of the cerebellum is to cause one group to relax while another group is contracting, okay? So for example, while the quadriceps are contracting, the hams are relaxed. That is what this neocerebellum does, and you get a useful movement. However, if you have decomposition of movement now, each joint will be acting on its own, and you're going to have what? Puppet-like movement. Puppet-like movement, okay? Okay, so this decomposition of movement now. And by the way, this decomposition of movement can be divided into several forms. So you can have this, sometimes we call dysdiadochokinesia. I don't know if you've heard about that. So he says to the man, sir, can you do this? Rapid alternating movement like this. And he can't. It be clumsy, he might say. And then you see him trying to adjust himself to try to fix it, right? But he can't do the rapid alternating movement. Sir, can you flex and extend like that? He can't do it.
So that is for the...
So these are signs of decomposition of movement.
And that's the...
Cerebellum.
Neocerebellum.
Yes, neocerebellum.
And you said spinocerebellum is for
Posture,
unconscious...
for posture, tone and gait. And it needs some information to be able to do that.
Okay.
Right? And
So
it needs-
proprioceptive information,
Yes.
vibratory...
Right,
like,
and so on. And those are all unconscious, right? So look here now, we're dissecting now this decomposition thing, right? What it means. So one of them we say is dysdiadochokinesia, right? Which is the inability to do rapid alternated movement. Supination and pronation are alternating movement, but they can't do it rapidly. They can't flex and extend rapidly either. Everybody get that? Good. Another one is this, guys. Another one is this. You know, you've heard them talk about dysmetria. Dysmetria. Metria means measurement, right? So you say, sir, can you point at this? Or can he touch this? Or even ask him to touch his nose. And he has great difficulty. So you ask him to touch the box. And he may overshoot or undershoot. But because he's not blind, you know, when he overshooting, he realizes what's going on and he trying to correct it. Whereas us now, we just do it one time. You understand? He said, touch it, so I just touch it there. But him now, trying to touch it and he go all the way over there and he say, oh shit, I'm going over, and he try to correct it. So you can see there's a break in what he's trying